Welcome everybody. I'm very excited today. I've said to a group this morning, this is probably the most excited I have been about giving a presentation, because for me this is coming out after a big career change, and it's also about our program emerging after 2 years of infrastructure building with demonstration that we can deliver output. It's a whole lot of new stuff. I think it's new for New Zealand. It's certainly new for me and my team, and we think it's really quite cool, so we hope you enjoy it as well. This is the team that worked most closely on this piece of work. So we have myself, Lucy Collinson, who did a lot of the background work and the liaison and the finding of the parameters, Yorgi, who has done the modelling using microsimulation, Rachel, who's contributed across the board but particularly to the costing, and Di, who has brought her experience in cancer control and particularly with some of the data that we use at the microsimulation level. Right, so this is an output of the burden of disease epidemiology, equity and cost effectiveness program. What I'm going to do though is I'm going to focus mostly on the question here about colon cancer care coordinators, but hopefully showcase to you the infrastructure we've developed and what we can do for not only this evaluation but evaluations like this in the future. So the structure is going to be that we're going to look at what is a cancer care coordinator intervention, the model structure that we used, input parameters and assumptions, some results. I'll skip the last sub-bullet point on results if we push for time, and then some implications for decision makers now and then for researchers and future evaluations. So you're probably aware that care coordination has become a bit of a priority for a whole range of reasons, but one of those drivers is the announcement in the 2012 budget of $33 million for better and faster services, including $16 million for care coordination. And I think it's fair to say that most people in the sector thought, great, oh hell, what is a care coordinator and how do we do it? So we have entered into doing an evaluation in that context, and people like Rachel and Lucy have liaised with people and actually helped, I think, solidify what a care coordinator is. So we've defined the care coordinator intervention as thus. The role of a care coordinator is to work with individual patients and their whānau to provide information support and psychosocial support, navigate them through the health system, and connect them with necessary health services both in hospital and in community. They also act as a point of contact for patients and healthcare staff, coordinate and track referrals, investigations and appointments in order to act on delays in diagnosis and treatment. And our research managers just caught my eye because there's something else I was going to do. We've got some handouts here for those of you who'd like a hard copy. So if you just flick up your hand, and Julie's going to wander around and give you a handout. I've got 25 here. I assume that not everybody wanted one. So Julia's quietly going to go around and hand those out as I keep talking. Thank you, Julia. Now, this is the Darren Hunt slide, who walked in late, but here you are, Darren. Here's your slide. He sent me a churlish email saying, well, what's the blinking comparator? Well, the comparator is essentially what we think has been happening on average across DHBs in New Zealand pre-2012. And it's essentially ad hoc patient needs assessment by nurses or surgeons or the house surgeon or whoever, often uncoordinated referrals, and no one individual being responsible for tracking those referrals. We think it's on average what was happening across DHBs, but we also have sort of conceptualised this in terms that fits the very scant literature there is, because we need to parameterise our model. So this is also a blend of what we think New Zealand was like and what literature we can leverage off. Now, we have a general approach to modelling, and this could be applied all over the place. So this is the general BODE approach. What we're trying to get to is we're trying to get to the cost effectiveness at the end of it, including by social group. And we do that by coming in and working out things called HALYs, health adjusted life years. They are very similar to QALYs, except that we allow for population morbidity and we use disability weights rather than utilities. But given the plethora of possible utilities, disability weight's really just another utility. So it's really not that much difference from QALYs. I'll show you some subtle differences as we go through the presentation. Now, we also got the net costs here. And what we do is we put a whole lot of inputs into the blender, which is called modelling. And we have baseline data, things like the incidence rate of colon cancer. And we have intervention data, things like the proportion of people that are going to shift from having surgery only to surgery and chemotherapy. Now, if we think a little bit more about the cancer care coordinator model, it's this. We used a form of modelling called microsimulation, discrete event simulation. And it works as follows, is that basically you can think of the pathway as diagnosis, surgery, this is for stage 3 colon cancer, diagnosis, surgery, chemotherapy start, chemotherapy end. And each box along the way here, you've got, on average, 3 competing events. When you're diagnosed, the next thing that could happen is you get your surgery, you die of the cancer, or you die of another cause. Let's say you get surgery first. Then you've got a competing next event of chemotherapy starting, dying of cancer, or you get my point. You've got sequential events here, and our job is to model individuals through that process. And as far as how the cancer care coordinator intervention can have an effect, it's essentially by reducing the time from here to here, reducing the time from here to here, and possibly, well, we actually modeled it as probably, improving your quality of life in here because it reduces anxiety. So that's the 3 ways that the care coordinator can improve your HALYs. Now, I've deliberately not put the table on here because this is going to freak you out. So whenever you do a model, there's a lot of input parameters you've got to put in. And there's the baseline stuff, and then there's all the stuff about the intervention itself. Now, to make it very clear, we picked the hardest intervention we think we'll do first in BODE to get our feet under the desk. By hard, I mean the evidence base is scant, so we've had to use a combination of literature reviews and expert knowledge elicitation, which Lucy worked very hard on, and also Rachel on the costing side. Asterisks, things are called, one asterisk means that there's heterogeneity. When I say heterogeneity, I mean we allowed for variation in that parameter by sex, age, ethnicity, and deprivation. That's what I mean by heterogeneity. Double asterisk means we didn't actually put any uncertainty about that variable. Everything else has got uncertainty because we're unsure about its exact value, and we propagate that through the models. Okay, here's the table. That's what it looks like. Horrifyingly complex. But that's everything on one table, and we're going to look at it several times and work our way piecemeal for it. So first of all, we're going to start with the baseline parameters over here, and I'm just going to briefly walk you through those. So the first baseline parameters, you need to know how many people have got stage 3 colon cancer. The way we do that is, many of you may be familiar with this green book from the ministry, I call it. This mouth, there we go, the green book. That projects out to the future the rates of cancer incidence by sex and age, leveraging off cancer registry data from 48. But it doesn't include it by deprivation ethnicity. So what we do is we blend it with the stuff I've led, looking at the ethnic and socioeconomic difference in cancer incidence. Bang, we've got projections all the way up to 2026 in cancer incidence rates by heterogeneity. That's the first input. Second input is we need to know how people survive from their cancer. We do that with something called excess mortality rate modelling, which is the flip side of survival. Excess mortality, survival, flip side things. We use a whole lot of quite clever modelling to do that. And then what we do is we develop curves like this. So this is the excess mortality rate after diagnosis. I think this one might be for breast cancer, but anyway, the point's the same. And then this is your rate, which then turns into, we turn into a time to event by creating a cumulative distribution function about that. I'll come back to that in a sec. Any change, any effect by getting your treatment earlier is going to slightly alter that curve, and I'll show you how that works. The next 3 slides are for the methodologically inclined. If this is not your cup of tea, take a break. So what we do is we take that mortality rate curve here, and then we flip it. And we work out by time since diagnosis the proportion of people who have died of their cancer in this case, depending on whether you're Māori 75 plus, New Zealand European 70, you get my picture. Then what we do is we use these cumulative curves in the modelling as follows. We randomly draw a number between 0 and 1. This is called stochastic variation, or the random walk part of the model. And let's say we randomly drew 0.3, and it was a New Zealand European 75 plus. Then we go across here and we say, okay, they died at 4.5 years. If another event hadn't occurred between this. This is how you do the discrete event modelling. This is what drives it. And then the important point is when we model interventions, essentially what we do is we bend those curves down. So if we're going to improve survival, we're going to bend that curve down so that somebody who was randomly had a 0.3 and just died at 8 years, if they were New Zealand European 45, 54, will now become a survivor. That's how we do the modelling. Okay, so if you've just zoned out, we're just about finishing the methodology here. We do the same sort of thing for background mortality as well as cancer survival, and also time to treatment. Okay, we also need those background mortality rates. That's quite simple. We just use life tables, but again, based off the work I've led before with the NZCMS, we disaggregate those by sex, age, ethnicity and deprivation to get specific life tables which give us the competing mortality risk, or the DOC in that previous slide. We also need background population morbidity, and this is a measure of your loss of quality of life on expectation just because you've reached a certain age and you have a certain ethnic group. And what this has done, we leverage off the New Zealand Burden of Disease study here, which is where our collaboration with the ministry becomes most apparent. This is about to be published later this year. For 217 conditions, you work out the disability with it, and then you can work out the average level of YLDs, which we then turn into population morbidity by sex, age and ethnicity. So for example, if the PYLD at age 70 is 0.25, that means 25% of your full quality of life is gone because of, you might have osteoarthritis, the rest of it, and you've got 75% left. It's that 75% that we can model health loss or health gain within. The 25% has gone. And it looks like this. And these are the PYLDs by age group and by ethnicity and sex. So you can see here, as you would expect, that Māori have higher PYLDs, higher morbidity at any age. And what our job is to model the health gain within the remaining envelope above this line up to 1, which is off the axis here. Now that's epidemiologically really cool, but it has major value implications. We'll come back to that just before I finish. We also have cancer disease morbidity. I won't go through the details here other than to say that we took Australian disease models, the just published December 2012 new global burden of disease disability rates, combined them, calibrated them to New Zealand prevalence, and there are the disability weights if you're in diagnosis and treatment, remission, pre-terminal and terminal stages of colon cancer in New Zealand. So you've lost over half your quality of life in that last month of life if you're dying from colon cancer, and they're how we ascribe the morbidity or the quality of life part to our analysis. And any palliative, or in our case, anxiety reducing intervention is going to affect by changing that disability weight. Now, other inputs come from the work that Sarah Hill did in a PhD, supervised by myself, Di, and as a collaborative effort. And what she did was she went out and saw heaps of hospital notes, and from those hospital notes, got a whole lot of information about colon cancer patients, and we used that information to estimate the proportion of people who are stage 3 colon cancer who get chemotherapy. And then of those proportion of people, we use things called gamma regressions to estimate the time to getting that chemotherapy from your surgery. And what the gamma regressions do is they allow us to output curves like these, which differ by heterogeneity. So here's non-Māori 55 to 59-year-old females, and this is the distribution of times to chemotherapy with 50 days, 100 days there. Those are the distributions that we use to sample from when our random walks our microsimulation. So you can already start to get the impression there's a huge amount of infrastructure we've put into this to allow this type of modelling. Some of it's specific to this intervention, but some of it's generic to other interventions we'll do in the future. Now, current cost of the health system. This is, we're very proud of this, and this is because of New Zealand's unique health data we can do this, working with the ministry again. If you think about, this is classic Drummond diagram altered a bit for our program. And there's these health sector costs here that occur downstream. So if you keep somebody alive, they're going to cost the health system more because they're alive down there. Or if you make them in a better health state, they might cost less. But we need to know what those downstream health system costs are. And we've got Health Tracker, which essentially is a wonderful tool, wonderful data set, linking together all these types of data sets using the NHI number. Don't tell the Privacy Commissioner, but it's actually a population registry. And for each one of these events, people like Craig Wright, Anna Davies, and others in PHI at the Ministry of Health have linked the cost to them. And what we can do, this is described in 2 seconds, but this took a good year and a half of June Atkinson and my time, we can jump in and with careful manipulation of all the person time, pull out amazing data like this. So here we go, females aged 62.5, time pre and post diagnosis for colon cancer costs. And we can get the cost per month. Your first month post-diagnosis, first 1 to 5, you get my point. And also the cost if you die from the cancer. We just jump in there, grab all these costs, and they automatically populate our model, which is extremely rich, and we don't think many people around the world can do this. Otherwise, you've got to do all the costing bottom up, and frankly, it's awfully tedious. Right, so on the last of the baseline models, we have the cost of chemotherapy. Now, this was done by Rachel and Lucy. a standard costing and came in at $17,812 with that amount of uncertainty, standard deviation of that amount. I won't go into detail about that. It's other than to say it's including, Rachel, what are the drugs in it? Is the extra one, and then the standard chemotherapy prior to that. Sorry, I've forgotten the names on it. Okay, let's look at some of the intervention effects. So one of the things we have to estimate is the proportion of people who are currently only getting surgery who get shifted to getting chemotherapy as well. And we estimated that at 0.33. This was a very loose, as I told you, the evidence is scant in some of these areas. There was some literature that we could use to get a feel for that, and then we did expert knowledge elicitation with some of the people in this audience and a range of other people around the cancer control and cancer networks in New Zealand. Now, it's genuinely uncertain, so for variables like this, we specify wide uncertainty and then propagate that through the model because we genuinely are uncertain. So for example, this one here is the proportion surgery only that get chemotherapy. So our best estimate is 0.33, that's our average, and the average weight under this curve comes down at 0.33. The median's a bit less because it's skewed to the right. And you can see it goes all the way from nearly 0 up to about 0.8. So wide uncertainty, we'll see how that affects the results in due course. So this is one of the things you do in modelling is when you've got that wide uncertainty, you don't run away from it, you include it. Next thing we did was the hazard ratio. This is how much benefit you get from getting chemotherapy. That's it for standard, and then plus oxaliplatin. There's not too much uncertainty here, reasonably good estimates, not going to spend much time thinking about that variable. Now these ones are basically how much survival gain you get from getting quicker to surgery and quicker to chemotherapy. On the quicker to surgery side, the first bullet point, that was challenging to estimate, and what I had to do was go and find the natural disease models that get used in a colorectal cancer screening program, which give you the time that you spend in equivalent to stage 1, then stage 2, then stage 3, and then calibrate that up against the differences in survival. So that is estimate of uncertainty, and what that's saying is a 0.003 reduction in your excess death rate per day quicker to surgery, but with quite wide uncertainty there. Per day quicker to chemotherapy, there's actually quite a nice little paper by people, I don't know whether it's a he or she, Biagi and colleagues in 2011, who found a 14% increased mortality rate for a 4-week delay in getting to chemo. So we just reparameterised that as a relative risk reduction per day quicker to chemo as there, which is a slightly bigger effect than per day quicker to surgery. Now, really scant evidence is the effect on quality of life of a care coordinator. We found one study that used something called the Zung anxiety scale, and then we're able to find literature that used both the Zung anxiety scale and the EQ5D, transfer the Zung change to the EQ5D, and then we use various mechanisms developed by our colleagues in the University of Queensland to transfer that to a change in a disability weight. And what it turns out is that we think there's a 33% reduction in your cancer disability weight, which is pretty large, but anyway, 33% with wide uncertainty, again from 0.45 to 1. As far as the costing, I'm just going to sort of talk in general terms about this. This is on the intervention cost itself. We did event pathways, so you work out what happens to patients as they go through the system. Then once you've got the event pathway, you work out what resource utilisation there is in consultation with experts and other published studies and literature. And then you add the cost for each resource unit. We did it for both the intervention and, to keep Darren Hunt happy, the comparator. And then the effect of the intervention is the difference between the two. Now, when you do the difference between the two, one thing you might have noticed is actually the cost of the care coordinator between the surgery and the chemotherapy is diddly squat. Because essentially you're liberating resources. You're giving the health system back the time of the house surgeon, back the time of the consultant, because a clinical nurse specialist is stepping in and taking over those roles. So you've got the swapping. So not much net cost there. A little bit more net cost up front in the pre-surgery phase. Dietitian, there's more cost because that's introduced based on what we could see would happen. Likewise, social worker. Both these two costs actually have no health gain that we modelled. They're just part of the package of care. All right, results by 10-2, not bad. So there we go, drum roll. This is what it looks like. So this is called a cost effectiveness plane for those of you not familiar. What it shows is the incremental HALY gain per person. So 0.1 of a full year's quality of life gained here per person, per patient. It's obviously for total stage 3 colon cancer population. And there's the incremental cost. That's the cost of the intervention plus or minus any downstream health system costs. It's both got the downstream health system cost and the intervention cost in it. And the way you read it off is you look for all these points here. Now, each one of those points is 1,000 points here. Each one of those points, let's take the first iteration. These are 1,000 cycles in a Monte Carlo simulation. On the first cycle, you go and grab from all your parameters we're just looking at. The random draws, some value for the hazard ratio of chemotherapy, some value on the proportion of people who are going to be shifted from surgery only to surgery and chemotherapy. Grab, 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 grab. You've got a set of parameters. That's your outer loop. And then what you do is you do thousands. How many here, Yorgi? 64,000 random walks within that one first loop. Those 64,000 random walks in this instance, you first of all randomly select one of the 120 types of people we've got. 10 age groups by 2 ethnic groups by 3 deprivation groups by, I've missed something, by 2 sex. So there's 120 types of people. So you go and grab one of those types of people, and then you go and do those reading off of those time to event curves and randomly select from those. So we walk 64,000 simulations through that. And then when we've walked those 64,000 simulations through, we take the average HALYs gained and the average cost, and that is one dot on this curve. And then we do the one dot on this graph, and then we do the whole process again 999 times more. Because we've randomly selected by heterogeneity and the microsimulation or the random walk part in the inner loop, the results here show the scatter for the uncertainty about the parameters only. And this is the way that you would expect it to be standardly done in a cost-effective analysis. So there we go. So this is due to parameter uncertainty. Another rule of thumb. Rule of thumb is that if you can gain QALYs, and we're just using it for HALYs here for a moment, at a cost of something a bit like your GDP, our GDP is about 40,000 New Zealand dollars, per HALY gained, then that's a rule of thumb that might well be cost-effective. So the fact that these points are beneath that diagonal is suggesting we're looking at a reasonably cost-effective evaluation. So that's what we've got here, a reasonably cost-effective evaluation. Quite a lot of scatter up here, but notice that the scatter's this way, so that means that the ICE is quite accurately measured, even though there's uncertainty in the amount of HALYs gained and the cost. Because they're on that diagonal, the uncertainty around the ICE is not too bad. ICE stands for incremental cost-effectiveness ratio, dollars divided by HALYs gained. So if we think about it now, this is just taking this data visually and summarising it with numbers. So there's our mean incremental cost coming in at about there. So that's the weighted average in there. The median would be a bit further up here because of the numbers higher up here. And indeed it is. There's the median. Well, yeah, no, it's a bit less. I've got it wrong. We'll ignore that. Moving along. Incremental HALYs of 0.121, which is sort of reading off at about there, etc. And then you can draw from these distributions the 2.5th and the 97.5th percentile, and you end up with an uncertainty interval. So we say that the uncertainty about the gain in HALYs is from 0.07 to 0.185 per patient. Remember, this is per patient. And there's your ISO. 18,000 is our best estimate, or 19,000 if you want to round it, with a range from 13,000 to 25,000. The upper limit is less than our rule of thumb of $40,000 per HALY, so we say that this is cost effective. That's our conclusion at this point. So this is the key result, if you like, of the presentation before we go and look at various bits of by heterogeneity, and it gets the BODE green tick. Now, just to emphasise, I've got this at the bottom of a lot of slides. I'm very committed in this program to getting results out early to decision makers. I don't really care what international journals say, but just help me out a little bit. If you do want to cite these, please contact me first. It can be cited correctly as a personal communication. And if a referee has found an error in our work and we've had to update, I'll give you the updated version. So please use them, but please contact me before you cite it and say that to anybody you give the results on to, just so that we can operate in an environment between the research priorities and the decision-making priorities. Now, what drives those HALYs, those net costs or incremental costs, and the ISA? What we've done here is we've done a whole lot of scenario analyses about various bits of the model you could change to see what's driving it. Now, we're using what we call expected value analysis now. It's not the full simulation, because each one of these full simulations takes how long, Yorgi? 4 hours? 6 hours?
This is 20 hours.
Yeah, 20 hours that takes. So we used some shortcuts called expected value analysis. So you're not going to see uncertainty intervals now. But what we can do is we can compare the values, because just the comparison of the absolute values gives us a feel for what's going on. So our expected values are slightly different for the mean for the best model, just because of the way that distributions work. And the first thing we can see is that component, when we take out we do the component for diagnosis to surgery only, there's very little cost of it, but also very little HALYs gain. Not much of the benefit of this program comes up to surgery. Most of the benefit comes between surgery and chemotherapy. However, probably with quite considerable uncertainty, the cost effectiveness of this part, if you believe our parameters, is actually better than that between surgery and chemotherapy, but you get much greater HALYs gains between surgery and chemotherapy, so you get your bigger health gain there. One always does, everything I've done so far and everything else I'll show you in this presentation other than these two bottom rows is with a discount rate of 3%. That's the default one in our protocol. So if you use 0% discount rate, you increase the amount of HALYs gained. If you use a higher discount rate, that's discounting the future more. So if you keep somebody alive and they're still alive in 20 years' time, it doesn't count for much because you've discounted it away. Therefore, you see a reduction in the HALYs. And you also see that the ICE is a bit less with a 0 discount rate and a little bit more with a higher discount rate. I'm not going to talk any more about that because I'm just going to work on 3%. Okay, in these remaining slides, what I've done is I've highlighted in red the things that I think that are interesting to talk about. So this is a whole lot of scenario or sensitivity analysis about variation to the epidemiological parameters, largely those that are about the effect size. But some of these are also background ones. So here, remember those PYLDs, that graph of the increasing morbidity for Māori and European? Now, if we just set them all to 0 and take them out of the model, we actually start to approximate a QALY, because QALYs don't include that population morbidity. Bonwin's going to argue with me in question time about that, but we'll do that then. But what happens is that the HALYs goes up because you're not penalising people for getting older and having comorbidity. So what you see is the ISA therefore goes down because you're not allowing for that morbidity. Now it's the same when you set all disability weights, including the PYLD, to that. Now by also setting the disease disability weights to 0, you've now shifted it from any quality of life to just being life years saved. Okay, so your life years saved ICE is much the same as that for stripping out the PYLDs as it happens. Going to ignore those for now. Right, the two things that really matter in this intervention is when you exclude the increasing percentage of patients getting chemotherapy. That shift from surgery to chemotherapy is important. If you don't allow that shift from surgery only to getting surgery and chemotherapy, you lose 45% of your HALYs. So it's a big driver of this model. And likewise, if you exclude the improved survival due to quicker to chemo, so you've shifted people to chemo and then they get it a bit quicker, on average 20% quicker, 20% fewer days to chemo. If you exclude that, you lose 25% of your HALYs. So this is what's really driving the health benefit of a care coordinator as we modelled it. Now, those two numbers are actually even more important for older people because older people have longer time to chemo and they also have lower receipt despite eligibility. We think a lot more older people, and this is where Les Dienert, who's one of our key informants, and Andy Simpson, who's a medical oncologist, you know, we worked out exactly what percentage of people we think are eligible, and we think a lot of older people are missing out. So you get a bigger effect there. Now, thinking about the cost parameters, if you remember that health tracker data where we jumped in and grabbed all the data and we pulled it all out again, if you vary those up or down by 20% because of the 3% discount rate and also because of the cost of chemotherapy being quite large, when you move those up and down by 20%, you really don't change it by much. Okay, so it's not too important in this model. In other models it will be, but here not too important. If you exclude that dietitian and social worker intervention cost, it actually reduces the cost quite a lot, from here to here by 23%. And as I said before, we think that's part of the package, and therefore we think it's in the best model, but we don't actually model a health benefit per se off it. You could say that better nutrition improves your survival, but there's so much uncertainty, we wouldn't even dare try and model that. Now, the other thing we do, and this is in our protocol, and this is what we think is the best approach to modelling, but it is contestable and people argue for it, is that once you've survived your colon cancer, and we say if you're still alive after 8 years, you're a survivor, we still count the cost you'll accrue to the New Zealand health system by still being alive compared to if you've died. So we include those future unrelated health system costs. Now, I think that's the best way to do it, although I shoot myself in the foot sometimes with that because, for example, a lot of smoking interventions might not become very cost effective because by killing people off as they're getting older, it's quite, cost saving. But anyway, that's our point of principle. We leave those in. But if you take them out, if you're a type of person that doesn't like those unrelated health system costs, then you reduce the cost, the net cost or incremental cost intervention by 21% and therefore the ISA by 21%. So there you go. That's trying to give you an idea of how the results move around for different assumptions you could bring to this modelling. In all instances, it appears cost effective if you use that rule of thumb of $40,000 per HALY or QALY or life year. So to sort of sum up at this point, most important, and I think to get the most important, you look at the HALYs gained, increasing coverage of that chemotherapy. So we're now starting to think about, we've just done stage 3 colon cancer, but we want lessons here to apply to cancer care coordinators elsewhere. So it's about getting people to effective interventions. It's not rocket science, but with the benefit of modelling, it becomes clearer. And decreasing your time to that chemotherapy or decreasing your time to effective interventions. And if you look at it, if you don't like HALYs, we like them, but if you don't like them, we can get an ISA for a pseudo QALY here, it's about 25% lower, and an ISA for life years gained that's also about 25% lower. So they're the key summary points in the last few slides, as I think. You may have taken other points out of it. Now, here's that cost effectiveness plane again. And now what I want to do is I want to talk about heterogeneity. That's how the HALYs gained, the cost, and the ISA varies by your sex, age, ethnicity, and deprivation by heterogeneity. So the first way to get a visual look at that is what we do is, remember we did the 1,000 outer loop and the 64,000 inner loop, and in that inner loop we were sampling types of people but averaging across them. Well, we just take those types of people and we put it in the outer loop and just leave the stochastic or random walk in the inner loop that we average over. And now when we plot points, it includes both the scatter due to parameter uncertainty, but also due to being a different type of person, sex, age, ethnicity, deprivation. And what you can see is the scatter on the blue dots is much wider than for the green dots. And what you can immediately therefore see is that there's a lot of heterogeneity in here. That is, the net cost, the net HALYs, and the ISA are going to vary depending on what type of person we're talking about. So that's that point there. There is significant heterogeneity. So this is something quite cool you can do with these microsimulation models, is examining this and getting a visual representation. So let's jump on in and do it another way. So we've now coloured them. Red is younger people, and less than 65 of colon cancer is young. And green is those greater than or equal to 65 years. So if you're younger, you tend to get more HALYs gained, you tend to cost a little bit less, and therefore your ISA is going to be lower. So you can immediately see that this is a more cost-effective and more effective intervention for younger people. Point being, and I'll put this in the last slide, second to last slide, if you're in a cancer network and you've just appointed a care coordinator and you're stretched for resources, push them out to your younger patients in the first instance if you're looking for more cost-effective and getting a greater gain in the long run. True, your older people who are not getting as much receipt, you might get more of them into chemo and you might get more immediate benefit, but if you're thinking about the HALYs gained over the life course, then you're probably going to get a bigger bang for your buck amongst the younger people. Now, that was by age. I'm going to ignore sex because it doesn't vary too much. So there you go, there's the ISA for younger people, the incremental cost effectiveness, the cost per HALY gained, and for older people, so quite different there. And I think when we did it with the uncertainty intervals, uncertainty intervals didn't overlap, if I remember rightly. No. Now, here I'm doing it by ethnicity and age simultaneously. I'm going to show you this graphically in a sec in a more easy way. Just for now, note there's not too much difference in the ISA for Māori and non-Māori combined, but when we stratify by age, things change a little bit. Because, of course, the Māori population amongst the colon cancer patients will tend to be younger than the non-Māori, who will tend to be older. So one way that we're looking at this, and we're now getting to a part of the program where we want to understand equity, but first we do it through understanding heterogeneity. Okay? So one way to do it is as follows. This is a 4-point cost effectiveness plane. And what I've done is I've plotted on there the expected value, that is the average, of the HALYs gained and the cost for non-Māori greater than 65, Māori greater than 65, Māori less than 65, and non-Māori less than 65. And I call these the epidemiologically correct. So I think everything we've done to this point in the modelling is smashingly epidemiologically correct, and I'm incredibly proud of it. However, it's got a kicker in it. We're going to get to the kicker in a sec. So you see that as you are younger here, you tend to be further to the right, as we saw before. Older, not as far to the right, and you cost more. And so you can read off your ISAs here. The ISAs are in the parentheses there and should be exactly the same as what you see down there. Now, here's the kicker, is that epidemiologically correct does not equal a value-free analysis. At some point, you have to pull back and say, well, what are we doing about the social values underlying the way that Tony Blakely as a boffin designed this whole thing? And they're our best estimates. Those dots there are our best estimates of what would actually happen. That's what we think would happen. However, they also value health gains differently by ethnicity in particular. In that a life saved for Māori has fewer HALYs gained for two key reasons. One, remember they've got the higher comorbidity, so they've got less well envelope left to work in, so they've got a lesser space to gain their HALYs in. And the other thing is, of course, with a gap of life expectancy of 7 years, the mortality rates, the background mortality rate, their competing risk is higher, so they're more likely to die of something else. So when you save a stage 3 colon cancer patient's life in their Māori, you're going to be gaining less life years because of those two reasons. But you can argue about that on a value basis. You might say, well, actually, we don't want that in our model. We actually want to have a neutral valuation at that point, because essentially assigning a weight to the HALYs at that point. Now, the way we're approaching this, just to remind you of what we're working off here, the PYLD's now been useful for policy to say morbidity is higher for Māori, let's do something about it, but when we use it in modelling, it actually penalises Māori. So this is where Melissa McLeod, who's one of the co-investigators but also doing a PhD, is doing, this is what she's doing her PhD entirely about, is to work out what are the best way to present this. At this point, we have what we call the default BODE equity analysis. In the default BODE equity analysis, we simply assume that everybody has the best life table, which is least deprived, deciles 1 to 3, non-Māori. And we also assume that that Māori get the non-Māori PYLDs. So we take those two things out. We still leave sex and age variation, and we still leave variation in incidence and survival differences. But we take out the things that affect the rewarding or the weighting of the HALY. And when we do that, you see a tiny shift from here to here, because all you've changed is the deprivation profile, but you shift things a long way over here for Māori. You gain more HALYs because you've allowed more space to gain the HALYs and you've allowed a longer life expectancy. You also increase the costs slightly because they're living longer and therefore costing the health system a little bit more. But what you've done, for example, for Māori greater than 65, you've changed the cost effectiveness from 25,000 per HALY gain to about 18,000. So you've essentially made it, you've introduced an equity weighting in there and given an alternative ISA for policymakers to consider. This is one that we're going to be pushing around the traps and seeing how policymakers find this, whether they find this useful. But for now, it's our default BODE equity analysis. So what can we say at this point about equity or heterogeneity? Now, it's really important at this point to remember you've got a patient level and a population level. Everything I've done in this presentation so far has been at the patient level, simulating individuals with colon cancer. So at the patient level, we can say the following. I have to emphasise this point. Extremely proud of what we've done. Think it's epidemiologically really cool, but there are assumptions in there like crazy. And essentially what we're doing is we're doing structured assumption making, structured assistance to policymakers to make a decision, accepting the assumptions and the structure we've put around our imaginary world. Given that structure and some of the assumptions, for example, we assume the percentage reduction in time to chemo is the same by ethnicity, and if Māori are waiting longer, therefore the absolute number of days they gain on expectation is greater because we assume constant percentage. If you assume all those things, then for the epidemiologically correct analysis stratified by age, HALYs gain per patient are 34% to 40% greater for Māori, so it's pro-equity on HALYs gained. But the incremental cost is 50 to 100% greater for Māori, so the ISA is 10 to 40% higher for Māori. That appears to be less cost effective for Māori, this intervention. You gain more HALYs per patient, but less cost effective. For what we're calling our default equity analysis, though, the HALYs gained per patient are now twice as large for Māori. The net incremental cost is twice as large, therefore the ISA is much the same. And this is the type of parameters we'll be exploring with policymakers to how they find that useful. Therefore, we conclude that at the patient level, cancer care coordinators are likely to be inequality reducing in health outcomes, that's the HALYs gained, for both the EpiCorrect and equity analysis. But cancer care coordinators are as less for the EpiCorrect or equally cost effective, depending on which way you look at it. So that's how we're introducing our quantification of equity into the analyses. Remember though, orange Māori, purple essentially non-Māori, European other, but the Māori rates of getting colon cancer are less than for Europeans. So even though the survival is worse, the incidence rate is less. So for all your patients standing in front of you, there are populations behind them from whence the cases arose. And if you now consider the gains you get from a cancer care coordinator and don't divide them back per patient, but divide them back by the population, you're going to see a lesser gain for Māori because the rate in the population is less. So the way it works is as follows. So when you take an age standardised HALYs per person in the population, they'll be much the same between Māori and non-Māori. So whilst per patient you gain more HALYs for a Māori person, you shift them both up like this, more for Māori, but there's fewer cases of colon cancer, so when you take it back to the population, it becomes much the same. This is where the difference between patient and population level. So that is, cancer care coordinators for colon cancer will not really do much for wider population level inequalities. If your mission is to reduce the gap in life expectancy between Māori and non-Māori, you're probably not going to achieve it through cancer care coordinators because you're dealing with disease with a lower incidence amongst Māori, even though you're getting bigger gain per patient. Now, compare that with a cancer with a higher incidence amongst Māori, and the classic example here would be lung cancer. Because the incidence rates are 3 to 4, sometimes even 5 times higher for Māori, any gain you get there is going to start to have quite a significant effect at the population level. And so that's work that we've got forthcoming on these issues. Yep, we've got time to do this. So what I've done so far is I've given the overall results, what essentially drives it, which components of the model, which components of the intervention drive the key parameters of HALYs gained, incremental cost and ISA, and then I've showed you how it plays out by heterogeneity and introduced you to what we call our default equity analysis. Now what I'm doing is remember those parameters we put in, particularly that 20% reduction in time to time to chemotherapy. We specified wide uncertainty about it. Well, what we're going to do now is we're going to look at how much that uncertainty in each of the input parameters drives the uncertainty in the outputs from the model. So your uncertainty in inputs propagates all the way through the model and then becomes uncertainty in your 3 key outputs of net HALYs gained, net cost and the ISA. So that's what we're looking at right now. And there's a standard way to do that in health economics called a tornado plot. And it works like as follows. What you do, and again this is expected value analysis because we didn't want to spend 16 hours doing each one of these. So this is expected value analysis. So what you do is, let's look at the HALYs first. So the HALYs read off the top axis, the net cost off the bottom axis. And what we do is we take the 2.5th and 97.5th value of each input parameter and see what happens to the net HALYs and the net cost. So when you take the lower end of the uncertainty distribution for decreasing days to chemotherapy, you shift your HALYs from the best estimate of 0.111 down to, I don't know, be about 0.80. When you take the high end of our uncertainty distribution about decreasing days to chemotherapy, it goes up to that. And what you can see here is the wider the bar, the more uncertainty that's coming through into those final outputs from uncertainty in the input. So it's called a tornado plot because I've ordered these based on their contribution to the ISA. So you order it from highest to lowest. So it looks like a tornado. Just going back to the components though of HALYs and cost, you can see that what's driving the uncertainty in HALYs and cost is that decreased days to chemotherapy, how much quicker you get people to chemotherapy, because we're very uncertain about that. And it plays out in the final HALYs, not so much in the cost. The proportion surgery only in the baseline who then get switched to getting surgery and chemo, we increase the uptake of chemotherapy. That's really important. The uncertainty of that causes uncertainty HALYs, but look at the uncertainty of the cost. Very wide. Because the major cost in this model is actually the cost of the chemo. It's not the health system cost, it's not the cost of the intervention per se, it's the cost of that chemo. You're shifting people to a very effective intervention that's about $18,000 worth per patient. So therefore, uncertainty in the proportion it gets shifted ends up in uncertainty in the cost. The decreased excess mortality rate, or the excess mortality rate ratio, or the improved survival per day decrease in time from surgery to chemo kicks in a bit. You get the point. You can see which things are driving it. You can see that these things down the bottom, even though we were uncertain, the decreased disability weight due to cancer care coordinators. Remember, I was really nervous about 0.67. I thought, wow, that looks quite big. And it ranged from 0.45 to 1, the relative risk. That's how much reduction you get in your disability weight from the care coordinator being very good at soothing anxiety. Well, it doesn't play to cause much uncertainty output. So you would not, as a researcher, spend time or HRC money going and researching that more if your goal was to estimate the outputs here, because it's not going to improve the model much. This is where you spend your time as a researcher improving your epidemiological estimates. And that's what it looks like by the ISA. So this is, you've seen the ordering now, so you can see which ones drive the most uncertainty in the ISA. Okay, so last two slides, and then we'll open it up for Q&A and discussion. Implications for the decision makers in the audience and in the health sector, and for researchers and future evaluations. So these are just, there's a lot more than this, but just one slide on each. So for the decision makers, well, it looks cost effective for stage 3 colon cancer. So we've got to caveat that. We've dealt with a cancer where it appears to be cost effective. Your job as decision makers before we do other evaluations to think, well, would the same principles apply for lung cancer? Would they apply for melanoma or whatever? More so for younger people. I nearly put Māori there, but it's mainly age that's driving that. Cancer care coordinators appear to be an inequality reducing intervention at the patient level, but it's probably neutral at the population level, at least for colon cancer. If you're doing something in the lung cancer space where the incident rates are that much higher for Māori, then as long as you're doing a reasonable job and getting similar HALYs per person, you're going to be doing an inequality reducing one at the population level as well. If you're in a DHB or cancer network with well-functioning coordination and timeliness to care, that is, your current position is better than what we modelled as the comparator, and then you go and introduce cancer care coordinators, you're going to get less HALY gain. Not sure about the cost, but I'd have to model that and think about it, but you're going to get less bang for your buck. So for example, some of the networks have very well functioning multidisciplinary teams where some of this coordination is done in that team environment. If you're in that type of environment, you'll be less inclined to institute a cancer care coordinated program on top of that. This is me just theoretically hypothesising. For those people more experienced in the health sector, they may have an alternative view on that. Now, if your cancer care coordinator resources are stretched, direct them first to younger patients if you're looking to get your maximum gain per buck spent. And work on, this is stating the obvious if you like, and I guess the modelling sometimes reveals the obvious, work on increasing coverage of known effective interventions and time to those interventions. Now, the implications for researchers and future economic decision modelling, well, the first one is celebrate success. We can do it. This is proof of principle. We have created a major infrastructure here that we can use for all sorts of things and been able to demonstrate these new methods and do it. I think this is a major breakthrough. Stand to be corrected, but I'm pretty chipper about this. Regarding the cancer care coordinator model per se, we could reduce uncertainty further by more research on what the actual increase in uptake in chemo is and reduction in the hazard ratio per day. But given that none of the sensitivity analysis about that shifted it to something that was cost and effective, I don't think it's worth putting your research buck here. Move on to the next evaluation and something else. But if you wanted to get narrower uncertainty about your model outputs, you'd do research in here. We welcome sector critique. If you don't like the assumptions we made or you think we've got it wrong, we want to hear about it. Because there is huge uncertainty here because the literature is not very good and we've had to use expert knowledge elicitation. Hopefully the scenario analysis we've given you, actually one of those fits your default prior or your prejudice, and you can therefore find the result you think's right. It would be possible to apply this model to other coordination interventions, and we welcome suggestions on other things that you want us to consider modelling. And those evaluations are forthcoming. And I'll finish up there to say that this program's got the tick, as has the team who conducted it in my view. Kia ora.
Thanks again, Tony, for a great presentation, and now open it up for questions and actually to help fill our won't make our colleagues feel engaged. Maybe they're open to ask the first question if they have a question.
Thanks very much, Tony. That's a fantastic and really interesting presentation. I hope I'm not the only one who's going to need a few more lunches to be able to digest this all the methods in here. One of the questions I have, I guess, from a DHB perspective is cancer care coordination is something that we think of in terms of, not just in terms of its ability to produce health gain, but also in terms of its ability to improve a patient experience, which may not be measured or totally measurable in terms of the improvements of health gain, but could be measured in a broader utility measure. I'm thinking, for example, about what happens when the anxiety that a patient has from the time that they've had their diagnostic test to the time that they get informed of their diagnosis. That may not affect a lot on their health, but it might have a bigger effect on their overall utility. Is it possible to include those somehow into your model?
Yeah, so two comments. First one is we're using disability weights. We're trying to value health state. Now, there's a real tension between what's a health state and wider utility. Is being happy part of health, or is happy not part of being health, that type of thing. I think, however, given that we put that 33% reduction in the disability weight for approximately the 6 months from diagnosis through to halfway through chemo, I think is where we stopped it, or to go all the way to end of chemo. We might have done it 9 months, I think. So even 9 months, it didn't make a lot of difference to the final outcome of the model. And so a third reduction in that disability weight, if you tried to bring in patient experience, which is not really disability, or it's not really a sort of a health construct, it's more something else, it would have to be a really big impact for a longer period of time to make much difference here on this way of looking at it. I realise you need to look at patient experience more generally, but I don't think it would change things in here too much.
Thanks.
Good, so maybe a question now from this audience.
We tossed a coin and I won. Thank you. It is really cool and exciting.
Thank you.
Tell me, why did you move from EQ5D? Why did you make that transformation?
For that particular Zung anxiety scale, because we could find no literature that had compared a Zung anxiety scale with anything that looked like a disability weight, but we could find some that had compared the Zung anxiety, which was the only study we had, we were able to creep it across to the EQ5D, and then we were able to creep that across the disability weight. It was just the only way we could get back. It was about it was a bit like what's the Minotaur getting back out with the string. That was the only string we had.
Other questions?
Right, sorry. Just because you named the slide after me, I felt obliged. And I'll be a little bit critical because you invited some criticism. And it kind of relates to the big green tick in a way. You showed us the rule of thumb, the 40,000 per HALY, which you could also describe as an assumed threshold. Now, of course, I'm going to comment, and anyone's welcome to comment back on this as well as Tony. Of course, what happens with that is you assume that all the other interventions that are either going on at the moment, or the other possible interventions you could do instead of this one, or the other things you could disinvest in, are worse than 40,000 per HALY. But in actual fact, all the things that you could do with into new money, or some money you get by disinvesting, for all we know, they could actually be around the 20 to 30,000 per HALY mark, in which case your relative cost effectiveness, this would actually be relatively cost ineffective. It's worse than all the other interventions. And I guess that comes back to my question about comparators as well. In reality, what is your decision? Is your decision to do this instead of the status quo, or is the decision you're faced with to do this instead of a different intervention, a different cancer intervention, for example? So in other words, that is your thing that you probably need to compare against. What else would you invest the money in, or what else would you disinvest in? There's my 2 cents.
Yeah, so there's 2 questions in there. One, should we be giving a green tick to our first evaluation? We've got no comparisons. And the answer is probably no, but I couldn't resist it. It was 11 o'clock at night when I put the green tick on. And we've got to start somewhere. And the idea in the program, I'm going to talk program and then wider. The idea in the program is to start getting a whole bunch of interventions so we see how our modelling generates stuff and get some idea of relativities. At the moment, we just have this rule of thumb. And then, of course, wider without the sector. But hang on a minute. How many evaluations do you know out there that are reasonable cost effectiveness about the things that we currently do or thinking of doing? They're done quite well for, not by, and not necessarily disclosed for pharmac by the drug industry, but we don't see them because price is internalised to the discussion, very effectively so, I must say. But we don't actually have a lot of other things to compare it with, and the idea is to get more of them done. Second point I'd make is that you started to scratch the surface of something I think is really important here for the managers in the audience and people who see this presentation. And I indicated in the presentation, if you've got a really well-functioning multidisciplinary team or some other mechanism to achieve care coordinator, you're probably not going to get the same bang for your buck that we've demonstrated here. All we can do is model a given comparator and a given intervention and present the results to you, and then you have to work out where you sit on that spectrum. That's as good as we can do as researchers.
Next question.
Thanks, Tony. Just a question around you at the start. You kind of talked about how the amount of delay in chemotherapy and what that results in, and also the amount of anxiety. I'm not sure I missed it, but was there discussion around how much these care coordinators can improve that and the evidence for that potential improvement?
Can improve the anxiety or improve the time to treatment?
Both.
Yeah, I flipped through it pretty quickly, but it's back here somewhere. My finger's getting tired. Getting to it. It's in there. So there, that's the percentage of people that move from surgery only and who are eligible. We lowered that threshold. So not 33% of all people didn't get surgery moved over. It was of those we estimated to be eligible. I didn't give you the maths on that because it's too much. And then the proportion reduction in days. So proportion reduction in days. So let's say you randomly drew for your Māori 70 to 74 this value here. Once you've turned it into a cumulative distribution, it's 120 days. Don't know why, getting quite long, but that's what we modelled for 70 to 74. So that's your first parameter you draw. You draw this person, this one of the stochastic random walks is going to have 120 days till they get chemo. And then the other parameter you drew about this one here was, let's say it was 0.2. Therefore, you're going to reduce it by 22 or whatever days. And that's your new time. So that's how we estimate it. The 0.2 comes from a range of studies which look at things in the US and other HMOs and elsewhere about the effect of care coordination getting people through to whatever treatment faster. We took that evidence and we showed it to the Marias of this world and other people. Does this approximate New Zealand and what would you put around that? And our best estimate was, in this case, 0.2, but just like the 0.33 one up here, with considerable uncertainty, so we can show you that it does or doesn't affect the model too much.
Thanks. The further question on that is, do you think that New Zealand will be resourced enough to be able to have quicker uptake rates? So is the coordination or just the resource availability?
Extremely good question. Okay, so I'm going to answer this with a methods, then a we didn't do it answer. Discrete event simulation, the method we chose to model, is actually one of the methods you use for dealing with queuing, which is whereby you've got a finite resource to pump people through. Now, our program, we want to do lots and lots of evaluations, so we decided not to spend more time on that because frankly this has taken enough time as it is. So yes, if that chemotherapy suite was chocker and you couldn't get more people in there, then you wouldn't achieve these benefits. But then it's about a transition, isn't it? It's the same number of people going through chemo, it's just getting quicker, so you've got to deal with that transition phase. So there we go, there's a bit of a loose answer. No, we did not directly model queuing or blockages or the amount of resource in the system. We're assuming that the system can equilibrate again to something happening quicker over time. Does that answer your question?
Thanks.
Yep.
Actually, just switching out to our wider colleagues again. Any other questions from
Ali.
any of you?
No, thank you very much.
Okay.
There's lots of them.
Thank you for that great presentation. I'm Trish Boyser, cardiac nurse for Financial Services. My question is, do you think it's too big a jump to say that the benefits gained from a cancer care coordinator could likely be applied to care coordinators in other specialties?
Well, it all depends on those effect sizes and what your potential gains are. So, for example, one of the ones we've talked about is lung cancer, where you've got to work really hard to get any survival benefit. The treatments are really poor, so getting people through their treatment faster may not get as much gain. It all depends. You need to sit down and think about it. You need to do very structured thinking about it, which as a decision maker, you may be able to take our results and make some comparison, and we might be able to do that too, and then it's about actually modelling it and seeing what comes up. So I'm giving you a hedged answer, I'm sorry. Depends on how plastic. Now, cardiovascular disease, the general principle, is very plastic. You can get good gains from getting angioplasty done or preventing it or whatever. It's very plastic disease, but something like lung cancer, not so plastic, or motor neuron disease or something like that.
Time for one more question.
Thanks. It's a clinical question. How does the HALY modelling work out on toxicity from the intervention? So more people getting chemotherapy, more people getting hospitalised from complications, toxicities, neutropenia, spending time in hospital and antibiotics.
Yeah, no, it's a really, really good question. I need to consult my modelling colleague. We stopped the disability rates for diagnosis and treatment once we had surgery, didn't we, in the model? Yeah. So the way, the way we did it is that higher, and you might want to challenge this, and that'd be fantastic if you do. Where's our disability weights? Back here somewhere. See those disability weights there? So you've got a diagnosis and treatment disability weight that is higher than your one in remission. So for somebody who was surgery only, they had that disability weight until 3 months or until they had their surgery. I can't remember which. Yeah, but then if they didn't get chemo, they went to this one. So we actually allowed for some, I'm pretty sure I'd need to go back and check the details, we allowed for that disability persisting longer if you had the chemotherapy. It's pretty rough, and we could actually change the model if you had a particular interest in it and wanted to suggest some alternative. You can explore that once you've got these models up and running.